You know, normally when we think about making a medical diagnosis, there's this like expectation of precision, right?
Oh, absolutely. Yeah.
It's almost like fixing a mechanical watch. You open up the back, you see a cracked gear, and the watchmaker just points to it and says, you know, there's the problem.
Right. It feels very binary, like broken gear, broken watch, simple.
Exactly. It's comforting because it's entirely visible.
Mm.
But step into the world of neurodevelopment, specifically the human nervous system, and that diagnostic landscape looks, well, a lot more like a sprawling city power grid.
That's a really good way to put it.
Right. Because a blown transformer in, I don't know, one neighborhood somehow causes a blackout on the entirely opposite side of town.
Yeah, it's incredibly complex.
So, welcome to the deep dive. We're taking a stack of clinical notes on cerebral palsy today, and our goal for you is to bypass the rote memorization of symptoms. We're going to look under the hood at the brain's wiring so you can actually, predict these bedside patterns before you even touch the patient.
And that's really the ultimate goal today, looking closely at that wiring. Because once we understand the actual mechanisms behind the physical exam findings, they stop being this disjointed list to memorize.
All right, they actually start making sense.
Exactly. They start making complete logical sense. We want to explain not just what the symptoms look like, but why they happen.
Okay, let's unpack this. We have a massive amount of ground to cover. Before we can recognize patterns on a patient's body, we really have to understand the primary wiring failure in the brain causing the vast majority of CP cases.
Which is spasticity.
Right. So let's look at what is actually breaking down in the corticospinal tract.
So spasticity stems from an injury to that pyramidal or corticospinal tract. And we usually think of this as the primary superhighway, right? Carrying voluntary movement signals from the motor cortex of the brain straight down to the spinal cord.
Like the move your arm signal.
Exactly.
Yeah.
But a critical and honestly often overlooked function of this tract is that it constantly sends signals to exert inhibitory control over your spinal reflex arcs.
Wait, inhibitory, so it's actively stopping something.
Yes, exactly. It actively suppresses your reflexes, keeping them from just, overreacting to every routine muscle stretch.
Oh, wow. So an injury here isn't just a failure to send a move signal. It's a fundamental failure to send the don't overreact signal.
You nailed it. When that descending pathway is injured, the inhibitory control is lost, and that results in a profound hyperexcitability of the stretch reflex at the spinal level.
So how does that actually look at the bedside?
Well, it presents as a velocity-dependent increase in muscle tone. So stretching a patient's arm very slowly might yield very little resistance because the reflex isn't fully triggered.
But if you go fast...
Right. The faster you try to stretch that muscle, the more intensely the reflex fires and the more resistance you feel.
Right.
That, combined with exaggerated tendon jerks, is the clinical hallmark of spasticity.
I always picture the nervous system like driving a car. We tend to think that an injury to the motor system means the steering wheel is broken,
Yeah.
Like you cannot voluntarily steer the car where you want it to go.
Sure, that's the common assumption.
But with spasticity, it isn't just a broken steering wheel. The brakes have been completely cut.
That is a perfect analogy.
The spinal reflexes are running wild because the descending signals telling them to stop are entirely missing.
And because those brakes are gone, the spinal reflexes just accelerate unchecked every single time a muscle spindle is engaged.
Okay, but I want to push back on something here, or at least clarify it. I've seen the term upper motor neuron syndrome, or UMN syndrome, used interchangeably with spasticity in the literature. Are they really the exact same thing?
I'm so glad you asked that. No, they aren't. Using them interchangeably is actually a very common clinical pitfall.
Really? Because you see it everywhere.
You do, but spasticity is only one component of upper motor neuron syndrome. To accurately assess UMN syndrome at the bedside, we have to divide the clinical findings into two distinct buckets, positive phenomena and negative phenomena.
Okay, so if the positive phenomena are the things that appear because that inhibitory control is lost, like the nervous system essentially doing too much, that would include the spasticity itself, right?
Exactly. Spasticity, the hyperactive reflexes, clonus, and that positive Babinskian response where the toes fan out.
Got it. Which means the negative phenomena must be the functional losses, the necessary signals that simply aren't making it to the muscles at all.
Right. The negative bucket includes profound weakness, rapid fatigability, and a really distinct loss of selective motor control.
What does that loss of selective control look like in real life?
Well, a patient might try to move just their wrist to grasp an object, but their entire arm and shoulder move simultaneously.
Oh, because they can't isolate the muscle.
Right. They've lost the isolated selective communication required for fine motor dexterity.
What's fascinating here is how those two buckets interact in a patient's day-to-day life. It seems to me like the negative bucket, the weakness and the total lack of selective control would be the actual driver of disability rather than just the spastic stiffness.
Yes. This is perhaps the most crucial insight of the entire spasticity discussion. The negative features are what truly limit the patient's functional independence.
Not the positive features.
Well, the positive features, like the overactive reflexes, the high muscle tone, we can actually treat those. We have pharmacological interventions like oral baclofen or uh, targeted botulinum toxin injections.
Botox, basically.
Exactly. Those calm the muscles down by artificially applying chemical brakes.
Yeah.
But we cannot medically reconstruct the lost descending pathways to reverse the profound weakness or to restore that selective motor control.
So you give a patient medication that completely resolves their spasticity, you get rid of all the extra stiffness, they still might not be able to reach out and write a letter.
Right.
Because the underlying weakness and lack of dexterity are still fully present.
Exactly. You've relaxed the muscle fiber, but you haven't restored the complex neural communication required for movement. The critical takeaway for you, listening to this, is to never equate controlling spasticity with restoring function. They are two entirely different clinical goals.
Okay, that maps out the microscopic disruption perfectly. Let's move to the macroscopic view. How does that disruption physically present across a patient's limbs? Because we know CP doesn't affect everyone identically.
Right, and this brings us to the topography of the injury. We actually subclassify spastic CP based on which limb segments are involved.
And I'm guessing this geographic spread directly reflects where the brain was physically injured.
Precisely. We start with monoplegia, which affects just one limb, though honestly, it's exceedingly rare to see in isolation.
Okay, what's next?
Then there's hemiplegia, affecting the arm and leg on one side of the body. And this is often asymmetric, so the arm might be significantly more involved than the leg, or vice versa, but the spasticity remains confined to one half of the body.
Right, and if we move past one side of the body, we get into diplegia, which predominantly affects both legs, though I think the arms can show some milder clumsiness, right?
Yes, exactly.
And as the geographic footprint of the brain injury grows, you'd logically see triplegia, involving 3 limbs, usually both legs and an arm, all the way up to quadriplegia, involving all 4 limbs, the trunk, and even the bulbar muscles of the face.
Right. Quadriplegia represents a massive diffuse injury affecting the motor strips bilaterally. But, what's highly instructive for a clinician is when these topographical patterns overlap.
Well, because it's not always a perfect textbook case.
Exactly. The patterns are not always perfectly clean. And that's where the bedside exam becomes a true forensic investigation into the patient's neurological history.
So what does this all mean when you are standing at the bedside? Let's walk through an example of an overlapping pattern that tells a deeper structural story.
Sure. Imagine examining a child who presents with a diplegia, so predominant spasticity in both legs.
Okay, got the picture.
Diplegia is very commonly caused by periventricular leukomalacia, or PVL. That's white matter damage around the ventricles of the brain. The descending motor fibers that control the legs run anatomically closest to those lateral ventricles.
Which is why the legs bear the brunt of a periventricular injury. That makes complete anatomical sense. The legs are affected because their specific neural cables run right through that periventricular blast zone, while the fibers for the face and arms run further out and are spared.
Exactly.
But what if you notice that on top of this leg-predominant pattern, their right arm and right leg are significantly tighter and more affected than the left side?
Then you're looking at a hemiplegia layered directly on top of a diplegia.
Oh, wow. So you have 2 different things going on at once.
Right. This combination tells you a story of 2 distinct overlapping injury mechanisms. The child likely has the baseline diplegia from the PVL, which is frequently associated with prematurity,
Okay.
but they also suffered a separate localized event, like an intraventricular hemorrhage on one side of the brain, which caused the superimposed hemiplegia.
That is wild. You are literally reading the history of the brain's distinct traumas just by tracking the stiffness in the limbs. The topography on the body and the underlying etiology in the brain are just permanently linked.
They absolutely are.
Okay, so we've mapped out the stiff spastic patterns caused by the corticospinal highway breaking down. But occasionally a clinician will see a patient who isn't stiff at all. right? Like they're moving involuntarily or they have zero balance.
Right.
That implies a completely different neighborhood of the brain has been hit.
It does. When the bedside pattern shifts away from velocity-dependent stiffness, we move into the territories of ataxic and dyskinetic CP. These presentations correlate with entirely different structural regions on an MRI.
Let's start with ataxic.
Okay, so ataxic CP is linked directly to cerebellar malformations or injuries. Clinically, it presents as profound incoordination. You'll observe an intention tremor, where a patient's hand shakes progressively more the closer they get to an object they're trying to grasp.
That sounds incredibly frustrating.
It is. Or you might see dysmechria, which is an inability to properly judge distance and scale movement.
So the timing and coordination centers are misfiring, basically.
Yes.
Then we have dyskinetic CP, which correlates heavily with injuries to the basal ganglia and the thalamus. The sources note that up to 70% of dyskinetic CP cases show structural involvement in these deep brain areas, specifically targeting structures like the lenticular nucleus.
Right. And instead of stiffness or incoordination, dyskinetic CP presents as abnormal involuntary movements. See, the basal ganglia are responsible for smoothing out and filtering intended movements.
So when they're damaged, that filtering just fails.
Exactly. This manifests as dystonia, which are these sustained, twisting, abnormal postures, or choreothetosis, which are irregular, flowing, writhing movements.
And there's specific historical causes for this too, right?
Yes, we see highly specific injury patterns based on the historical cause of the damage. Kernicterus, for example, which is brain damage caused by severe neonatal jaundice, classically shows preferential injury specifically to the globus pallidus within the basal ganglia.
I have to ask about this specific structural targeting. Why the basal ganglia? It reminds me of building a custom computer.
Okay, how so?
Well, if you install a massive high-performance processor, it requires a heavy-duty cooling system, right? If the cooling fan fails, that specific high-performance processor is going to overheat and fry long before the hard drive or the outer casing takes any thermal damage.
That is a brilliant way to conceptualize it. The basal ganglia possess an incredibly high metabolic rate. They are essentially the energy hogs of the developing nervous system.
So they need the most resources.
Yes. Because of this massive baseline demand, they are disproportionately vulnerable to hypoxic ischemic events, a sudden lack of oxygen and blood flow, particularly in term and near-term infants.
I see.
When oxygen delivery fails, the structure with the highest metabolic requirement suffers irreversible tissue damage first.
Form follows function, and vulnerability follows energy demand. And in severe cases presenting with a mix of dyskinesia and spasticity, that hypoxic damage doesn't just stop at the basal ganglia, does it?
No, it doesn't.
The sources show it actually spreads outward into central, cortical, and subcortical areas, even hitting the hippocampus.
That's right.
But let's say we have confidently linked these bedside movements, the writhing of choreothetosis or the twisting of dystonia, to this expected structural damage in the energy-hungry basal ganglia. We run an MRI, expecting to see that fried processor, but the imaging comes back completely normal.
This raises an important question, and it represents a critical diagnostic pivot.
Because it doesn't make sense based on what we just discussed.
Right. The sources point out that roughly 13% of dyskinetic CP cases have a completely normal MRI.
13%. That's not a small number.
It isn't. If you see a child with dyskinetic CP, a structurally normal MRI, and no documented historical risk factors like a known hypoxic event at birth, that normal scan shouldn't be reassuring. It should act as a massive red flag.
Because if the brain looks structurally intact on imaging, but the motor system is producing these severe involuntary dystonic movements, it suggests the foundational code of the nervous system is altered.
Exactly.
It fundamentally shifts the diagnostic pathway from looking for an old injury scar to searching for an underlying ongoing genetic condition.
Yes, and if we connect this to the bigger picture, we spend a massive amount of clinical time laser focused on the motor exam, the reflexes, the spasticity, the topography.
Which is important, obviously.
It is, but the motor subtypes only define the classification. It's the comorbidity burden that largely dictates the day-to-day care and the lived experience of the patient.
Here's where it gets really interesting. A full clinical assessment cannot stop at the limbs. Let's look at the mechanisms behind that hidden burden. CP involves widespread neural network disruption, which explains why comorbidities like intellectual disability and epilepsy are so pervasive.
Right.
The disorganized cortical firing doesn't just disrupt descending motor pathways, it triggers spontaneous electrical storms. causing seizures.
And because those global brain networks are heavily involved, you frequently see pseudobulbar-type speech and swallowing difficulties.
What does that mean practically for the patient?
Well, this is essentially an upper motor neuron lesion affecting the cranial nerves. It causes spasticity in the muscles of the tongue and pharynx. And this isn't merely a speech inconvenience, it leads directly to severe malnutrition.
Because they can't swallow properly.
Exactly. Feeding becomes incredibly dangerous due to the high risk of aspirating food or liquid directly into the lungs.
That's terrifying. Basic survival mechanisms like swallowing are compromised because the complex muscle coordination in the throat is completely disrupted by spastic tone.
Yes, it's a huge challenge.
The sources also list microcephaly, profound visual problems like strabismus, hearing impairment, and chronic sleep disturbances.
Yeah, and those sleep disturbances often stem directly from the injured brain's inability to regulate its own circadian rhythms and sleep-wake cycles.
Which must just severely compound the daily fatigue and neurological stress.
It absolutely does. Patients also frequently struggle with excessive drooling, which again ties directly back to that pseudobulbar or motor dysfunction we just talked about.
Right, the lack of selective control over the spastic muscles of the mouth and throat makes clearing saliva continuously difficult.
Exactly.
We also have to consider what happens to the physical body over time. If a child is growing but their muscles are locked in a state of constant spastic tension, the physical structure of those muscles is inevitably going to adapt and change, right?
Yes, and that brings us to contractures, which is a major focal point of long-term CP management. When muscles and tendons are constantly subjected to unregulated spasticity, they become shortened. This tightly restricts the normal range of motion of a joint.
But they don't start out permanently stuck, do they?
No, they typically begin as what we call dynamic contractures. This means the muscle is excessively tight due to tone, but with steady, gentle pressure, a clinician can still passively stretch the joint out to its full anatomical range.
But if the spasticity goes unmanaged, the continuous tension forces the muscle fibers and surrounding connective tissue to physically remodel and shorten permanently.
At that stage, the contracture transitions to being fixed, and once it's fixed, no amount of passive stretching or physical therapy will straighten the joint because the structural length of the tissue has permanently and physically changed.
So what do you do then?
Often, the only remaining option becomes orthopedic surgery to physically cut and lengthen the tendon.
Wow.
This physical progression from dynamic tension to fixed structural remodeling highlights exactly why early, comprehensive management of these musculoskeletal comorbidities is just so vital.
It really paints a picture of a deeply interconnected ecosystem. Let's summarize the journey of this deep dive for you listening. We started by exploring the true mechanics of spasticity, discovering that it is fundamentally about the loss of inhibitory brakes in the corticospinal tract.
Right.
We broke down the upper motor neuron illusion, realizing the negative functional losses drive the disability, not the positive spasticity we can medicate. We mapped the geography of the limbs, decoding how overlapping patterns like diplegia and hemiplegia reveal the anatomical history of specific brain injuries, like periventricular leukomalacia.
Which is such a powerful diagnostic tool.
It really is. Then we looked at why the basal ganglia are so uniquely vulnerable to oxygen loss due to their massive metabolic energy demands, leading to dyskinetic CP. And finally, we uncovered the hidden burden of comorbidities, from the physics of aspiration risks to the permanent structural remodeling of fixed contractures.
If there's one overarching principle to take away from these clinical sources, it's that managing CP requires addressing that entire interconnected comorbidity picture.
Not just the limbs.
Right? We must manage the malnutrition, the uncoordinated swallowing, the unorganized sleep cycles, and the communication barriers to truly impact a patient's overall quality of life.
Here is where it gets really interesting, and I want to leave you with one final thought to mull over, building on that genetic red flag we discussed earlier. If a completely normal MRI in a patient with dyskinetic CP strongly points to an underlying genetic cause rather than a structural hypoxic injury, could some of the cases we currently lump under the broad historical label of cerebral palsy actually be entirely distinct yet to be discovered genetic conditions?
It's a fascinating possibility.
As we continue mapping the human genome with increasing precision, how might that redefine how we diagnose and eventually treat these bedside patterns in the future? Maybe one day, we won't just be looking at the city power grid to find the blown transformer. We might actually be rewriting the biological blueprint of the grid itself. Thanks for joining us on this deep dive. Keep questioning what you see at the bedside.